Hello, my name is Javier Montero, and it's a real pleasure to be here with you in this winter school from AudioOS. I'm speaking from Valencia, Spain, and I'm going to show you some interesting clinical cases that I hope you enjoy. These are my financial disclosures, none of them relevant to this talk. And as you probably already know, you can use Navilas laser as a subthreshold laser or as a photocoagulation laser. The main diseases or retinal diseases that you're going to be treating as a subthreshold laser are chronic central serous retinopathy and diabetic macular edema. Well, I'm going to focus in chronic CSCR. As you already know, it's the fourth most common cause of macular edema. And if we have to compare the subthreshold laser, we have to do it with photodynamic therapy. Well, let's talk about the pros. For subthreshold laser is that you don't need Visudyne, and that's quite an issue nowadays. Still here in Spain to get Visudyne is not as easy as it was before. And let's say that if you don't use Visudyne, you're going to avoid Visudyne reactions. So that's quite an obvious question, but it can make the difference. And what about the cost? Well, this is more difficult to calculate, but let's say that in the long run, in the long term, if you're gonna treat a number of patients, it could be cheaper with the subthreshold laser in the long term. What about effectiveness? Well, here the photodynamic therapy is still the best option for your patients, as the PLACE clinical trial said. But let's say that this clinical trial didn't use the Navilas, that I think is going to make the difference. And I'm gonna tell you why. Well, I think that when you are treating with subthreshold laser, you are treating in a no view point, so you're not going to be able to accurately see where you are hitting the retina, the overlapping, the intensity. I think that here the navigation for the subthreshold laser is going to make the difference. You're going to have the power, the pulse duration, the spot size, and you are going to be sure that you give this laser where you wanted to do it. Here you see the caution areas and the treated areas, so you can repeat it. You can go higher in your power the next time you do it if it was not enough. And well, you could treat it with PDT if you need it in the long term, the same patient. Let's go to some CSCR cases. So here we have a young 35-year-old male with this bubble of subretinal fluid. As we see here in the OCT, you have this subretinal fluid, but you have this photoreceptors elongation that's typical from CSCR. Here you have some erosion of the photoreceptor layer with this hyperreflectivity within the subretinal fluid that sometimes corresponds to the leakage point. Here we have the fluorescent angiography and the ICG, where you can see the leakage point. Remember that not always in the ICG you can see the leakage point. Depends on the size of the aperture in the RP. And now here we have the picture that we have taken with the Navilas, and you have to align both images. And now what you have to do is to start with the titrate. What's the titrate? Well, it's just to perform the laser starting from lower power settings and going higher until you see some bleaching, some whitening of the retina. So in this case, from this young man, you can see that we got some whitening when we were close to 1000 milliwatts. And now how you are going to treat the patients? Well, you are going to go in 1/3 of the power you needed to whitening or to bleach in the retina. So here's the report for this patient. These are the spots. This is the power, pulse, and spot size, and this is how you get the report for the next time. For just an instance, you need to repeat it, or you need to know what you have done. Okay, this is the 4 months follow-up visit for this patient, so it did really better. And this is almost 6 months since we have performed the laser that the CSCR is resolved. Let's go through a more difficult case. Here we have more than one leakage point in this patient, also with subretinal fluid, and this is how it looks. You can see that in the fluorescent angiography we don't have any more leakage, and the subretinal fluid is resolved. You can also see here the spots from the titrate that we use to get the best laser power setting for this patient. And I'm gonna show you the real life video of this last patient, how you can perform the laser. So in this case we need almost 1100 milliwatts to get some whitening of the retina. So now we place the laser to 1/3 of the power setting. So here you can see that we are 320 milliwatts. We are working, remember, in a micropulse 5%. We're gonna use 100 milliseconds for the pulse duration and 100 microns for the spot size. All are performed close together with no spaces, 0 spaces between spots. You can see that we are doing it with a contact lens setting, and that the patient you could feel that it's painless and it's quite friendly to do. So and what about the photocoagulation therapy? Well, there's no new things about the photocoagulation. As you already know, you can treat ischemic areas that you could have in diabetics, in vein occlusions, etc. Or you could use it as a focal laser to get away from lipid exudation from microaneurysm, to treat efferent or afferent vessels, or you could treat rheumatogenic lesions as retinal tears, holes, or lattice. And what are the pros and cons for that? Because if you could do it with a regular photocoagulation laser, why performing Navilas? Well, let's say this is, in my opinion, the pros from Navilas laser. First, it's you could use it as a contactless laser, and I think that it's very much comfortable for both the patient and the doctor that is doing the laser. And you could use it using the infrared. That it's gonna give you a more comfortable view of the retina while you are deciding where to use the laser. Remember that you don't need to use bright color light to see the fundus of the patient. You can work with the infrared. I think it's a lot more comfortable, and I think it's extremely important that you have the report of every laser that you have performed, so you can get the plan and the laser report that you have done in each patient, and you can attach it to the clinical chart, you know. I think that is safer for you and for the patient. And the accuracy, I mean, here you are going to be sure that you are going to hit wherever you want to hit the retina. You have the caution areas where you don't want to hit the retina, and this way you're going to be able to get closer to the macula in case you need it. Of course, the cons would be the learning curve. I mean, it's an electronic device and you have to learn how to use it. So let's go through some cases. Here we have a nice view of a retinal picture with this pseudoedema. We can see that still some blood coming from this bunch of new vessels that are close to an ischemic area, as you could see here also in this white field OCT angiography. And let's see how we set the laser in this case. So we have already imported the fluorescent angiography and we have taken a retinal color picture with the navilas. So first we are placing the caution areas. So you are gonna perform the laser in a safe way. And then this is a tactile panel, so you can touch it, you can go zoom in and out, and now you can just draw wherever you want to treat this retina. Remember, you can also work through the spot spacing, so you can go closer or farther in the spots. And remember, you're performing all this setting even with the patient out of the office, so you just need a picture of the patient. You can plan everything. You can go again through the fluorescent angiography. You can just, in case you need it, you can erase some of the spots that you may want to spare the vessels or the hemorrhage or whatever, and go again and draw whatever you need. So let's go to the laser. This is a real view of the patient when he was given the treatment. So as you could see, it's quite fast, and you can see that the patient is moving the eye. So we're working a contact lens setting, and you are avoiding, well, some overlapping, and the laser was done correctly. Here we have my 4th year resident, Miguel Ortiz. He's doing the laser in a diabetic patient. In this case, he decided to use the contact lens because this patient was moving too much, so blinking too much. So I wanted to show you how fast you could go also with the contact lens. But you can also use it for easier cases, as you could see here. We just have a retinal tear, so you take the picture from the patient, you place the caution areas as you want, and now you just draw the spots around the retinal tear. You ask again the patient to place the chain into the navilas slit lamp, and now you just right away starts your treatment, as you could see in this image, in this video, and still painless. This is the posterior 1 week follow-up visit color pictures, and you can use it even in non-collaborative patients. This patient didn't let us to use the contact lens for the regular laser, and he had some lattice in the real far periphery. So it was really challenging for us. But as you can see in this video, we took the picture, taking the patient to look all over his superior right side, and now we draw the laser treatment for this lesion, this peripheral lesion. So we start the laser. Remember, contactless laser, and here we're trying to do even the anterior part of the lattice, And now we're gonna try to go to this more peripheral retinal lattice. We take another picture, and as you see here, we are able to do the posterior part of the lattice. We start right away now with the color view, just asking the patient to move as far to the superior version of the superior view of the lattice. It's quite hard to get it, but I remember it was very, very, very peripheral. And now we are going into a manual setting, and we do it manually. And you could use also the laser for focal laser, just to get away from lipid exudation. So here you have this lipid exudation secondary to vein occlusion, quite common nowadays. After anti-VEGF treatments and everything that you are doing nowadays, sometimes you get some lipid exudation from secondary microaneurysm. So with the Navilas laser, you can select all the leaking points that you want to get treated, and it's safer. Let's say this is not the most difficult case, but it's safer going with caution areas and knowing that the laser is going to do tracking of the patient eye movements. Here we have another case, secondary also to vein occlusion with lots of telangiectasias that produce this lipid exudation that you could see in angiography as these black spots all over the temporal area. But there are more difficult cases. I remember this case was driving me crazy because it was a young woman with this microaneurysm, dilated vessels, just very, very close to the right fovea, with this intense lipid exudation. And I found that Navilas would be useful in this case, so as it was so close to the fovea. This is the Navilas report, just once I finished the laser. And I got to say that I need to do a lot of things with this patient. I need help for getting away from this all lipid exudation and the macular edema. But let's say that now, after dexamethasone implants, surgery for the eventual epiretinal membrane that she developed, and a few sessions of Navilas laser, the patient is doing better and better. And here, well, this is also a difficult case, a tough case. This is a retinal color picture of a 64-year-old male. Here you can see in the left image the ICG that I have done in 2017 of this patient. He was diagnosed with a neovascular pachychoroid, and even if we have treated this patient quite a few times with anti-VEGF, in 2020 the patient developed this RPE detachment with this round lobular lesion below the RPE that was suspect there was a polyp, aneurysmatic type 1 neovascularization. So we repeat the ICG. As you could see here, this hyperfluorescence in the ICG that correspond with this polyp. The same happened to the left eye of this patient. He also developed this round lesion below the RPE with this hyperfluorescence in the ICG. The curiosity, I have this image just to show you that this patient in 2017, in the same place where the polyp developed, there was nothing. But even in January 2020, there was nothing here. And suddenly in June, just 6 months later, you see the double layer sign and the polyp is already there. So these lesions tend to grow sometimes quite fast. But nothing happens. You have a polyp, let's inject the patient, 3 injections, And what happened? Well, the lesion, you see the polyp got bigger, but okay, no worries. We treat again with 3 more injections, and whoa, what happened here? The polyps is getting bigger and bigger. We have quite a big size of the polyp now. What do we do now? So this is what is taking us to this Nabila's webinar. Well, we repeat the ICG in this case, and we confirm that the polyp was quite bigger than a few months before these 6 intravitreal injections of anti-VEGF. We record to the video ICG. We were trying to focus on the feeding vessel of this polyp, but I found it quite difficult to see the feeding vessel of this case. So I thought, okay, let's have a plan B. What would be my plan B? Well, let's do an OCTA. And surprisingly, the OCT angiography showed me very clear this vessel going directly to the polyp from the neovascular pachychoroid. So I planned my laser focusing in this vessel that I also was able to see it in the ICG. So I overlapped the images from the Nabilas and the ICG, and I set the laser to treat this feeding vessel. And this is the result. Just finishing my laser. This is the OCT angiography that you could see that the vessel was closed. This is the immediate image from the polyp that you can see that it got some hyperreflectivity in the lumen of the polyp, and this is what happened to the polyp. Finally, we get away from this polyp. Well, we have used it in real tough cases. I remember this bone hip Lindau patient. He got like a decade ago a previous TTT for a big hemangioblastoma in the right eye, and we were treating now this. We had to treat this small lesion. But what happens in this patient, in this young woman, was that she has some severe dyskinesia that makes the laser impossible with the regular laser. With the Nabilas in a contactless setting, we tried to do it, but she moved so fast. It was quite difficult, and we managed to move a little bit the laser to the left side of the hemangioblastoma, and finally we got the laser spots in the right position. This is the before and 1 month follow-up for this. So in conclusion, navigation laser I think is the future. I think accuracy and safety is the most important issue here, and I think that the subdermal laser is going to be a must in the future, and I think we all are gonna have lasers with navigation to gain in all these items. So I don't want to finish without saying thanks to all my team, starting from my boss, Dr. Cervera, the rest of my retina team, Dr. Navarro Castro, Dr. Monferrer, and all the residents that helped me with the presentation and with the treatments. Thanks